Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined by Dr. Chris Hobson. He is the Chief Medical Officer for Orion Health. Chris, thanks for joining me today.
Thank you so much for having me, Nick. It's a real pleasure to be here.
So, as I do always, I think it's important to get a little bit of the background. You have a hint of an accent. I can certainly tell at least the general area that's from, but it brings a little bit of interesting experience to your role. Tell us a little bit about your background and how you arrived at this role and what you're doing at Orion Health, if you would.
Sure. So the accent is from New Zealand. I've been in North America for 20 years, but the accent doesn't drop.
Well, just listen to me. Everybody knows as well.
My kids sound North American, so that's something.
So do mine.
Yeah.
There are a lot of common.
You can't be James's parent because you don't sound like him. Yeah.
Right.
So coming from New Zealand, it's a small country on the other side of the world, known, I think, for innovation and for some things. And, the current way that we've handled the COVID-19 pandemic has really kind of raised the credibility of New Zealand in some of these ways. But my own personal journey was I sort of 6 years in hospital medicine, 10 years in primary care. And I knew I was obsessed with IT and computers and trying to find a way. And I kind of stumbled on a job at South Auckland Health in New Zealand. And they said, well, what we want is to do integrated care. And you can be responsible for the IT and reaching between the hospital and the community. So we put together a lot of different software solutions, but also business models for how we could work better with the community. The basic problem was there was a high rate of meningitis that was seen as in the surrounding area, this really high area of meningitis. And then we realized that it was actually in the poorer part of town, and it was parts that are traditionally where the indigenous First Nations populations were living, Pacific Islanders and Maori. And so we kind of got into this whole thing where the hospital was being overloaded and struggling to meet the needs of the community in which it served. So from there, the software that we developed was very successful in things like disease management and also this concept of an integrated record. The idea we had at the time was the patients seen in the community or seen in the hospital, the provider who sees the patient would know all about them. So we inadvertently kind of stumbled from the needs of a poor, overcrowded part of town into this whole place of integration and interoperability. So I joined Orion and I've done various different roles. So currently, the two pieces to my role is, one is the clinical care. So are we meeting the needs of clinicians? What's the direction? But the other part of my role is what we call thought leadership. So you try to see what's happening in the next year or two. I try not to look out, 5 years. I think it's relatively easy to look ahead 5 years and there's going to be quantum computing and blah, blah, blah. So try to look ahead 1 or 2 years. For the US market, which is our biggest market, we've got really COVID-19. The equity issues are really big as well. So, and the two are entangled. So those are the kind of the business drivers for our clients, but also CMS and ONC have these new rules that they want. They want fire APIs. And so we've also got to meet the compliance things. So it gives us a full plate of things for 21. I think for our clients, even more so if I'm, a population health manager or an IT manager, I'm trying to understand what's going on and I've got to react to all these urgent needs with COVID. And yet I've also got to meet new rules and regulations.
So
that's where we are.
Interesting. You talk about predictions, and you know, one of the things I would say about that: the further out you go, the less likely you are to be held accountable for those predictions.
Yeah.
So I'm going to predict 50 years from now
Yes.
we are X, Y, and Z. Now there are some people that are good at that, but you know, I think it's right. We're sort of closer in, and obviously. You know, your capacity to see into that clinical experience, I think, is essential. You know, one of the things that really strikes me about this is the sort of the balance between personal healthcare, which is really I want to say a rising activity, a rising focus. People talk about personalized healthcare. I know I always say I want personalized medicine. I don't want the, you know, run of the mill for the thousands or millions. I want just for me. But how does that interact with the sort of population based statistics, and how do you see all of that interplay?
A very interesting topic. So absolutely, as personalized medicine, you're going down a path of genomics, for instance, to understand better exactly what each individual's susceptibility to disease. Even at a less advanced kind of level, to really personalise the care of a patient, you need to know all about them and then come up with a plan that's unique to their needs. Where we've kind of got to on that space is the ability to pull more and more types of data. So, for instance, I listened to with great interest to your interview with Medtronic Chief Medical Officer and the cardiac rhythms. So that's personalised medicine again, in a sense, because patients at home and you can get this data, which previously you couldn't get. So on the personalised space, where we've got to is we've got the clinical data, the claims data, the patient-generated data, and I think that's very important, the patient, what their perceptions and what their ideas and needs are. The social data, as much as we can get it, which has a big influence, behaviour, and the genomics. And so personalised medicine is often framed as genomic medicine, very similar. From our perspective, it's more knowing all about that patient so that you can deliver the best care for that individual patient. So population level is obviously of interest to people who write the checks for software as well as healthcare transformation and all these other things. So if I'm a payer in the US or a minister of health, you know, in the UK, I would need to be able to show, right, as no surprise today, I need to be able to show somehow that COVID-19 is getting better. But even before COVID, I need to show that in the UK, especially and in New Zealand, wait times are coming down, or I need to show that, you know, the mortality from cancer is improving. So at a population level, you need to know all about what's happening in that population, and then you need to know whether the interventions that you're putting in place are actually working. So we kind of hit on this shared care record or health information exchange in the US. So in the UK, we have a number of sites in Scotland and in England and in Ireland that use the shared care record. So that various counties in Scotland, all of the healthcare activity that happens in that county is all in one place. And then across Scotland, we have our deployments in multiple counties, and you can be in one county and look at the activity in the other counties. So in the US, it's more things statewide. So give me all of the data in New Mexico. So we recently kind of worked in the state of New Mexico, partly for the Department of Health, partly for the providers, put together a complete solution so I can treat my individual patient really well. But as the Department of Health, I can also see what's happening. I can see where the COVID cases are happening in New Mexico. So then I can direct resources appropriately to that end.
So as you think about that sort of interplay between the two, you talk a lot about health exchanges and, the shared care model. What strikes me about the challenge there is interoperability seems... it's a never-ending problem. I mean, it's been a problem since I can remember. It was a problem when we had paper notes because we couldn't read anybody else's writing. Now it's a digital problem. How do we go about solving that?
Well, I think it's incremental to, not to be too
singing
your praises. Yeah. I mean, the truth is somewhere in between. I think the standard HL7 V2 message, which gives you a lab result, electronically, that's been around since early 1990s. So one of my experiences in primary care in New Zealand was so let's say 1995, I had a full service EMR. I had automatic electronic lab results and radiology results. By 2000, I was involved in installing, but electronic documents, discharge letters, and things like that. So to some extent, we do have interoperability, for instance, in New Zealand, and I know a number of other countries, Denmark and certainly a lot of the UK, actually had achieved a lot in interoperability terms, fairly early on in the piece. Over time, what's happened is HL7 decided, and rightly, I think, but was tricky at the time, that the V2, the simple messages, weren't going to meet the full needs of healthcare. So they wanted to have a better XML-based, fuller description of the patient to exchange. And so in the US, we've done a lot with the CCDAs, the Continuity of Care Document, and now with FHIR. So FHIR, again, is fundamentally, it's an XML specification for healthcare. And we've been looking at it for probably 4 or 5 years now. I can tell you that it is a very good standard. I think that's first and foremost. The reality is that the FHIR version 4 is a very good standard for describing healthcare. And I really think we just have to say, okay, quit all of this. Shall it be this or shall it be that? Let's go with the FHIR. I have, around the very edges, I found the odd thing where it doesn't quite, it sounds like it still needs a bit of work, but that's all. It's a really good standard. Which brings us to when will we achieve it? So 2021 is going to be very interesting because CMS and ONC have these new rules and they are expecting and then demanding that health organisations will be able to exchange data using a FHIR standard. Now, the really interesting, from a policy perspective in the US, is going to be the information blocking principle. So the issue is, over the years, one of the things that's held interoperability back in the terms of actually achieving it in the US has been that, as a rule, hospitals and health systems are all competing. So some of our clients were able to convince providers in their state, they would go around them all and say, okay, let's agree not to compete on the data. So even going back 10, 15 years, for instance, in the state of Maine, they were able to convince all of the providers in Maine not to compete on the data. So share the data. We can compete on quality and, waiting times and all those good things, but we'll agree to share data. Unfortunately, across the entire population in the US, there has been still a lot of competitive pressures which make people reluctant to share data. So hence the information blocking rules, which will come into force this year. And it's going to be very interesting. I think everyone's really watching that. It now means, as a provider, you can't retreat and say, well, this is HIPAA protected, so I'm not going to tell you the data about a patient because it's, everyone retreats to privacy. That's the theory. In the reality, of course, devil's in the detail and exactly how well we find people's ability to steer between maintaining the privacy of health data, which is also such a huge topic, and then the ability to share it. We've got the FHIR APIs. We've got the information blocking rules. So 2021 is going to be the year to watch for sure.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Chris Hobson. He is the Chief Medical Officer for Orion Health. We were just talking about information blocking, which hot topic today. Chris was just explaining that, new regulations that are enacted, and sort of suggests that maybe part of the reason that you've seen success in some of these other countries is that we don't have information blocking, because that's not about technical problems. It's about economic issues that drove some of that. So I wonder if, the differences in these systems has helped some of the progress that I guess you've seen in some of these other countries and with, the other clients. And I know you and I share a little bit of heritage in terms of different systems. And I'm not here to sort of suggest, we should all move to this alternative, but you've obviously got personal experience for other systems. Any thoughts on that and the impact and where we might see some change, perhaps driven by COVID, maybe?
Yeah. So I think first and foremost, up front, it is easier to do things like interoperability and some of these things. It is easier to do those in New Zealand, in Denmark. We've done an enormously, referenceable, highly exciting project in Alberta. But Alberta is 4 million people with a single payer and a lot of control over everything that moves. So in all of these discussions, I always like to say, when it comes to the US, we have to acknowledge up front, 330 million people. So that's 6 times the UK, more or less, 5 or 6 times the size of the UK. So right up front, you've got a much larger population and a lot more heterogeneity is just baked into the population. So you could say the Canadian model works very well at one level, that we have individual provinces, and we've been really successful at providing shared care records across many of the provinces of Canada. But then Canada's only 40 million, and each province, apart from Ontario, is less than 5 or 7 million. So it's just easier. I do think we have to get the funding model right. As we're saying, you get what you incentivize. And again, I think I'm really hopeful in the US that the understanding that fee for service has meant when you pay for services, you get more services. It doesn't mean you get improved quality. So we've had our toes in the water around accountable care organisations and other value-based care models. And maybe, I think, about 30% of the US population are now covered by an accountable care organisation. So it's a good model. But each, again, you've got so much heterogeneity. You have health systems like the Kaiser and the Geisinger, where they're both payer and funder, or the church-based organisations, Adventist Health and so on. And so it's just harder. When you look at the EMRs in the US, there's well over 100 different EMRs, or EHRs. It's just a different order of difficulty to integrate with them than in New Zealand we had 7. And I remember I went round all 7 EMR vendors, said, "You've got to play ball. Your competitors are playing ball." One insight from those days actually was the new vendor on the block was always keen to do the latest standard. And we didn't really even have to pay them, but maybe if we gave them $5,000, they would be very grateful. And the incumbent vendor was like, "Well, we've got half of the primary care practices in New Zealand, so you're going to have to talk to us." So, it cost us a lot more to bring them around, a lot more time and effort. So even in a small country, you get the same kind of dynamics.
So we're hopefully on our way to sort of providing interoperability to help exchange information, maybe learning from some of these other systems. One of the things that I continue to hear about, and I know you think about a lot, is this sort of virtual care and the digital front door that, has to be part of our future, not just because we're all sort of confined to this matrix world that we've lived in for the last several months, but, it makes a lot of sense. I mean, I think people have realized suddenly, actually virtual care works. Not all of the time, but, instead of getting in the car, driving, parking, all of those things, and the digital enablement, once you got that fixed, once everybody got their cameras and, all of that technology, How do we go about, what are the steps to get us there?
So, there's no going back now, I think. We've proven that
let's hope not.
Virtual care works and people have got the technology. So the interesting piece on the virtual care, of course, is, so on the one hand, the patients absolutely love it. From a patient perspective, myself, the other day I had to see somebody and, instead of going there and sitting and waiting in the waiting room with a whole lot of other people and then getting in front of him and, last minute, which would take 3 or 4 hours, could even take out my afternoon, I was able to sit at my desk, do my stuff, 10-minute phone call consultation. I'm happy, they're happy, everybody's. So that's the patient side of it. I think patients are very happy with virtual care. Two sides. So from the physician perspective, I think we still have a little bit of anxiety about whether it's safe. What if we need to examine the patient? You can't easily examine them over the phone or whatever. So there's still that, and, I just need to see you. Well, okay, but why? is the response from the patient, but from the physician, I'm just so used to see I can put so much together. So that's one part. The other part, of course, is the payer's willingness to keep funding virtual health. So as part of COVID regulations, there was a lot of levers and rules and regulations changed, which enabled us to charge for a virtual consultation at more or less the same rates as an in-person consultation. So the payers will have a role to play, obviously, as we go forward, if we're able to keep going with the virtual care. The only other thing just to say is, so virtual care for COVID, when COVID is the dominant thing and every patient seems to have COVID, we've proven you can virtual care for a lot of simple things and you can virtual care for COVID. We are really concerned, the patient with the breast lump, the patient with, a bowel cancer who's being left at home. And so we have kind of put those people have suffered, I think. A lot of normal care hasn't been happening. So we have seen an increase in the death rate that seems to be more than just explainable by COVID. So I think that's also a little bit of an open question. If someone has bleeding from the bowel, can you handle that just as well virtually? And I think obviously there becomes a point where you have to go in and see somebody and sleeves rolled up, work out what's going on.
Yeah, I think no disagreement there. It's not a replacement; it's augmentation, and obviously, the appropriate sort of use and application for the right instance. In the closing minutes, if you could just tell us, where do you see things going? What's your sort of view of the future? Project out 10 years. No, wait, you said 5 years. I'll give you that. Where do you see us and what are you excited about?
To answer the second question first, I'm excited that as we've accumulated more and more data, we are able to make better predictions across a population. So an example would be, we did a study of, we have the population of patients attached to, say, a payer or a state, and we can comb through, find all the newly pregnant women and find, using the artificial intelligence and so on, find those who are at risk of having a high-risk pregnancy, identify those people, and then put them on a better plan. So that's one view of the future where we can look through the population, find the problems and address them. Then I think as we look out, so on the non-technical side, aided by AI, I'd like to say that we can find the problems, we can find, and that we can do something to help. So we can show that there's a lot more COVID in a poor part of town and overcrowded with essential workers, and we can send the other hope is that the system will start to respond, and population-based funding does get you there. You now need to care about those people at the bottom of the heap. So that's what I'd really like to see. Technology-wise, I think obviously everything's going for the cell phone. Everything's computing power is increasing relentlessly. Again, I would like to just see more of the humanizing aspects to technology being considered. I think the information, the disinformation and what we've learned through Facebook and all of that, if we can start to address those things, then I think we actually have a bright future. You know, technology can actually make a real positive difference to people's lives. I can see how, but it is going to be on us to avoid the downsides and the negatives, which, you know, unfortunately show they can happen.
Fantastic. Well, as usual, we've run out of time, so it just remains for me to thank you for joining me. Fantastic, interesting journey and exciting and positive potential. Chris, thanks for joining me today.
Thank you so much, Nick. It was a real pleasure.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.